with that, I'll get on to introducing my colleague, another colleague, Dr. David Horn, who's a pediatric otolaryngologist at Seattle Children's and director of the cochlear implant, co-director, sorry, medical or surgical director of the cochlear implant program here, and has a research lab looking at all kinds of interesting questions on perception and outcomes. So he's going to talk about surgical management of pediatric unilateral hearing loss.
Thank you, Dr. Steve, for the introduction, and it's a pleasure to be here to present on this topic. It's fun to go last, and it's fun to have all of these interesting talks. There's some stuff that I was going to cover that I don't need to. And then there's a couple of points that I want to make that I think will be of interest based on some of the early talks. So I was like typing furiously in real time to make some notes and make a couple really subtle changes. Well, maybe not so subtle. And I'm trying to advance the slides. Here we go. Financial disclosures. Here's my employment. I received an honorarium for this presentation, some salary support from the NIDCD. I'm going to talk about some commercial devices. I have no direct or indirect financial relationships to those companies. So I've added this. We're going to talk about etiologies, types of hearing loss, and patient factors that are relevant for medical and surgical management of unilateral hearing loss. We're going to talk about the mechanisms of action of the two basic device types that we're talking about, and then look at some of the outcomes from the surgical devices. I'm not going to cover surgeries that we do for creating an ear canal or fixing an eardrum or doing a sacculoplasty. It's a little bit out of scope, and these things are not specific to patients with unilateral hearing loss. And just really quick on terms, I'm going to try to use unilateral hearing loss. I think I might have single-sided hearing loss a couple of times on accident. And I didn't have time to change SSD to LUHU. I like LUHU. I'm going to try to use that more. But SSD it has the similar meaning in this talk. CI is cochlear implant, and BCSP is bone conduction sound processor. We've already talked about the natural history and the range of presentation for pediatric unilateral hearing loss, from congenital to later onset. It can present relatively slowly over time. It can be sudden. So sometimes the unilateral hearing loss is conductive. There's a variety of reasons for that. And some of these can be fixed, like cholesteatomas can be removed, perfs can be fixed. Sometimes it's permanent. And I just wanted to outline one of the inner ear malformations that can cause a conductive hearing loss is something we refer to as a third window effect. Here's an example of semicircular canal dehiscence. So this is the normal ear of a patient with semicircular canal dehiscence in the contralateral ear. So this is the semicircular canal. There's bone all around it. And if we look at, I'm trying to advance. I don't know why it's not working. And then if we look at the contralateral ear, here's the semicircular canal. It doesn't have bone on top of it. So these patients will have an air bone gap because of this. There we go. And then patients can have sensorineural hearing loss in their unilateral hearing loss ear. So when we look at studies that look at the etiologies in patients with permanent unilateral sensorineural hearing loss, in kids, the most common finding is cochlear nerve deficiency. So here's an MRI. It's the best way to evaluate the cochlear nerve. This is the normal ear over here. CSF shows up as bright signal, cochlear fluid shows up as bright signal, and the nerves show up as dark signal here. So this is the cochlear nerve here going straight to the modulus of the left cochlea. But over here, we get a little glimpse of the vestibular nerve, but you don't see any cochlear nerve on this right side. Some studies show an incidence of cochlear nerve deficiency in up to like 30 to 40% of children with single-sided deafness or LUHU. But we can see this kind of picture in children with lesser degrees of unilateral hearing loss as well. They can have other various cochlear dysplasias. We often will see something called an enlarged vestibular aqueduct. This is a patient with a left-sided sensorineural hearing loss who has an enlarged vestibular aqueduct in their left ear, but a normal aqueduct on the contralateral side. And sometimes this can be associated with specific genetic causes of hearing loss. There's some controversy in how common genetic hearing loss is found in patients with isolated unilateral sensorineural hearing loss. But there certainly are some genetic mutations that are more likely to be associated with unilateral hearing loss than others, and others that are often manifest initially in one ear and then they can develop in a contralateral ear. So congenital CMV is the thing that I wanted to add a little bit of content on based on our talk, on Dr. Tharp's talk from this morning. And I'll talk about that in a moment. I have that fourth here, but I think it's probably more common than we realize because it's under identified. Meningitis, trauma, there's sudden idiopathic sensorineural hearing loss. So I just wanted to briefly add a little bit of content about congenital CMV. So about 10% of patients with congenital CMV are very sick at birth, and they are all identified in the NICU because they have very specific characteristics. The majority of these patients will have some degree of sensorineural hearing loss. But the majority of patients with congenital CMV are what has commonly been called asymptomatic because they're not very sick. But a lot of those kids, 15, 20, 25% of them will have or go on to develop sensorineural hearing loss. And this kind of sensorineural hearing loss can be highly variable in its presentation. So this is a study looking at the natural history of sensorineural hearing loss in a group of patients with quote unquote asymptomatic CMV versus normal controls. And you can see that the incidence of sensorineural hearing loss grows pretty steeply by about age 2, but then there's still a little bit of separation between the case control groups up to maybe 6 to 7 to 8 years of age. So really later onset unilateral or bilateral sensorineural hearing loss can be associated with asymptomatic CMV. And when you're dealing with an infant who's a few months old, it's a little bit easier to test for congenital CMV. You can test their saliva, and if they are negative when they're a few months old, you can essentially rule out congenital CMV. If they're positive, it could be a false positive because they could have it could be a postnatal infection. So the blood spot is a tool that we use very routinely in our clinical practice to help tease apart congenital from postnatal infections, especially in the children who present with sensorineural hearing loss when they're 3 or 4 or 5, and saliva testing won't be sensitive or specific. We can get the blood spot from the Department of Health and do CMV viral DNA testing. It's not super sensitive to do it that way, but if it's positive, it tells you that that individual had a congenital CMV infection. There's some reasonable evidence that treatment with antiviral medications can help prevent some of the progression of hearing loss in patients who are the symptomatic version of CMV. And then there's emerging studies that are suggesting that maybe antiviral treatment can also be protective in asymptomatic congenital CMV. So when we are seeing these patients, if they have sensorineural hearing loss and we identify congenital CMV prior to 3 to 4 to maybe 5 months of age, we are referring them pretty routinely to infectious disease to discuss treating them with antiviral medication. That being said, this is not exactly standard of care. There was a consensus statement in 2022 that basically said there's insufficient evidence to support routine treatment in asymptomatic CMV. But I think this is going to change potentially in the next few years. There's a number of states that are doing congenital CMV routine screening. And this is probably about a year old. So there might be some more. Interestingly, in the state of Washington, there was a bill introduced and was passed, but it was modified to where the state's not mandating routine screening, but offering families information about the option of screening. And from my understanding, the state and the Department of Health looked at the evidence that was available as of early 2024 and concluded that there wasn't good evidence that medical treatment changed the outcome. So I think that's going to be something that changes as we get more information, not only about the efficiency and effectiveness of antiviral treatment, but also on the effect of early fitting with hearing aids or hearing devices in terms of preventing some of the problems that kids have that we've talked about already. And then one more caveat I wanted to mention is that congenital CMV is very common. It might be as common as 1 in 100 to 200 births in the United States. So, and the majority of patients who don't have symptomatic CMV don't develop sensorineural hearing loss. So if you have a child with sensorineural hearing loss who has congenital CMV infection, it doesn't tell you for sure that that's the cause. So it's still a good idea to look for other etiologies through imaging or genetic testing. And in our cochlear implant program and hearing loss clinic, we've seen several patients over the years who have a genetic cause of hearing loss and they also had congenital CMV, where we are pretty certain that the genetic cause is the primary cause of their hearing loss. Okay, so now let's get into what I was going to talk about all along. So surgical, we're usually thinking about surgical treatment of hearing loss, just like most surgeries in pediatrics, when there is not a non-invasive option. So if a child has no ear canal or has a chronically draining ear and can't tolerate an occlusive device, they are potentially a candidate for a surgical option for their unilateral hearing loss. And then this is the child who has LUHU or single-sided deafness, where they have no ability to benefit from amplification in their affected ear. So there's two basic device types. Bone conduction devices we've talked about. They're conducting sound through the bone. They bypass the external and the middle ear, but they do rely on a presence of a healthy, functional cochlea and auditory nerve. And then a cochlear implant is something that we're going to introduce that we haven't talked a lot about yet. And this is a device that electrically stimulates the auditory nerve. It bypasses a physiologically non-functioning or poorly functioning cochlea. But for these devices to work, you still need some degree of formation of the cochlea in order to place the electrodes. And you need a nerve that carries the information to the brain. So, well, first we'll talk about bone conduction devices. So we've already talked about the candidacy for both isolated conductive hearing loss or mixed hearing loss, as well as single-sided deafness. All of the surgical systems that I'm going to talk about here have two basic elements in common. One is the processor. It's similar to the softband retained processor that's been introduced, where it has a microphone and a sound processor, and then it has a connection in some way to provide oscillation to the skull base. So that can happen either through a direct connection to an osseointegrated or a surgically placed abutment here, or it can be an actual, and what we call that a passive bone conduction device, or it can be an active implant where the oscillator is actually in the implanted device and directly attached to the bone. We'll talk about both of those. So in addition to passive versus active systems, there's also systems that are percutaneous, meaning the implant sticks out through the skin, or transcutaneous, where the connection between the processor and the skull does not require an opening in the skin. So the Cochlear Corporation that makes the Baha devices and the OSIA has kind of versions in all three of these categories. So the Baha Connect is the percutaneous abutment version, and the Baha Attract is the transcutaneous passive version, where there's a flat metal magnetic disc that is screwed in to the surgically placed abutment. The skin is closed over it, and then the processor is held in place and creates oscillations that are carried through the magnetic coupling of these two parts of the system. So this is actually an option that loses a fair amount of the ability to transmit gain to the skull base. So it's not a good option for single-sided deafness, where you need to transmit the signal to the contralateral ear. And the OSIA is the active implant that has the oscillator as part of the implanted portion. Right. Medtronic makes the Sophono system, which is a passive transcutaneous device. This is the implanted magnetic part, and then there's a processor that's worn outside that transmits the oscillation energy through the magnetic field. Oticon makes the Ponto, which is a percutaneous device, and also the Sentio, which is an implanted active bone connection device. And then finally, we have the Medel Bone Bridge, which is an active implanted device. So when we're kind of helping, so there's a lot of different devices, different companies. So when we're trying to decide and counsel families on what system might be best for them, we have developed an OI BCSP team, so Osseo Integrated Bone Connection Sound Processor team, which consists of audiologists and the otolaryngologists, the surgeons. We try to see these patients in tandem, and we have developed a conference where we meet roughly monthly to discuss patients. And some of the things that we are counseling families on is the percutaneous devices have some downsides, in that there's some healing issues that can happen in the short term as well as the long term. There's also the issue about transmitting the energy through a magnetic connection, which I mentioned loses some of the energy and does not allow for as much benefit in cases of single-sided deafness, versus a direct connection. And also the issue with the active devices. So the active devices all contain an implanted magnet, and this magnet will cause some signal artifact under MRI that can make it hard to image that part of the brain. So that can be an issue in patients who need serial MRIs. In the older active devices, just like the older cochlear implants, the magnet was not MRI safe. Here's an example of a magnet moved in the MRI field. But in the more the current devices do have a magnet that is MRI safe. Programmable shunts are things that we don't want to place an implanted magnet next to, because the processor magnet could disable the programmable shunt, leading to problems. Cautery is monopolar cautery is contraindicated around the implanted devices. So for patients who are going to need these things in their short term, the active implanted devices are not going to be as good of options. The surgeries, depending on the type of device that we're placing, can be as long as about 90 minutes. I'm going to kind of skip through this. Here's an example of the incision we would sometimes used for the active devices. The other thing I want to say for people who are working with otolaryngologic surgeons who may or may not have close colleagues that do microtia, reconstruction, and atresia, placement of the incision for any of these devices should be made in close consultation with surgeons that do microtia reconstruction, because these incisions can affect the blood supply for later options. Here's an example of the percutaneous device. Here's the abutment retained processor with some skin growth over the processor. And this kind of system can make it impossible to hook the processor onto the abutment and requires surgical modification. So now we'll talk a bit about cochlear implants, just checking my time. Cochlear implants are all systems that have two basic elements. There's a processor that's worn externally, and then there's a receiver stimulator that is implanted underneath the skin and soft tissue against the bone. The receiver stimulator has a wire that connects to electrodes that are surgically placed into the inner ear, into the cochlea, through a small opening that we make surgically. So cochlear implants work by, I should say, the processor has a microphone and a signal processing computer inside of it. And then it sends radio signals through the skin to an antenna in the receiver stimulator, instructing the receiver stimulator about sending electrical pulses to these individual electrodes. So a lot of times people are wondering what cochlear implants sound like, and there's not a great way to know for sure what they sound like, but there are systems that can kind of model the amount of and the type of information that cochlear implant listeners can hear. So I'm going to just play you some extreme examples. So I'll play you this example first. This is somebody who gets very, very little benefit from a cochlear implant, and they only really perceive one kind of place of stimulation along the cochlea. So you try to understand what this is saying. So you may or may not be able to tell that that's speech. If we model a listener that has more channels of stimulation, it gets a little better. Anybody have any idea what that said? I don't know if you can respond. I'm going to guess no. So then this would be an extremely good cochlear implant listener with 12 channels of hearing, and we should be able to understand this.
Cochlear implant surgeons are the smartest and best looking surgeons in the hospital.
It's not a true statement. All right. So the cochlear implants have changed over the years. When the first devices had processors that were worn on. Lisa made a smiling face, so I'm assuming that was audible to people. So the processors were initially big and worn kind of at the belt, and now the processors are small. They're worn similar to BTEs, or they're worn off the ear. And all of the receiver stimulators have gotten thinner and more compact over time, making placement of the devices easier to close the incision, and a little bit less drilling to do. So cochlear implants are going to be indicated only for children with LUHU, or single-sided deafness. So it's children with lesser degrees of sensorineural hearing loss are not going to be candidates for cochlear implants. The current FDA criteria are children should be 5 years of age or older. And I forgot to mention that for the surgically placed bone connection systems, they are also FDA approved down to 5 years of age, with the exception of the bone bridge, which still only has approval down to 12 years of age. And then for a cochlear implant candidacy, they should receive limited benefit from an appropriately fit hearing aid. And that could be either a cross system or a soft band retained BCSP. And then they have very, very poor, essentially no speech recognition in the implanted ear. And then some other caveats. We're pretty careful about only selecting children with pretty normally developed cochlea. Unlike children with bilateral severe profound sensory hearing loss, we really have to get like a home run result with a cochlear implant for them to find it useful with a normal hearing ear in the contralateral side. We always get an MRI in these patients. In fact, when we get these referrals, if they haven't had an MRI, we get one before having them see our team, because auditory nerve hypoplasia is a contraindication for CI in this indication. Okay, and there's a picture of our cochlear implant program, our CI team. Like the OIB-CSP team, we meet twice monthly, and we have a bigger team here. And this team, Dr. C, I just calculated, this is the 30th year. So this program was started by Dr. C and Dr. Norton in 1995 with the first patient implanted at Seattle Children's. Cochlear implant surgery is an outpatient surgery for healthy kids above 2, but they stay overnight if they are younger. I'm not going to play this little movie, but I'll play the movie while I talk. Why not? So this is, we've made an incision behind the ear. And here we are opening the cochlea through the facial recess. And we're doing what's called a extended round window approach. So the round window is a natural structure that opens up into the cochlea. We make that a little bit bigger so that there's room for the electrode to be inserted. All right, and that's the electrode array inserted, and so on and so forth. Audiologists come down to the OR and they do some electrophysiologic testing of the device to measure whether or not the electrodes are working, whether we're stimulating auditory nerves, and they can also use that information to help set the initial maps when kids come in. And the postoperative, sorry, one second. Postoperative care, kids wear a pressure dressing for both the cochlear implants and the BCSP implants. They wear a pressure dressing for a bit, they take some antibiotics, and then we see them back 4 to 6 weeks or so after device placement for mapping and initial placement of the processor. Then for cochlear implants, a big piece of their outcome is having regular auditory rehabilitation therapy. Okay, so let's see how much time is left.
Thank you. Do we have a couple minutes for questions, Dr. Horn?
Yeah, of course we do. Yeah.
4 minutes left.
Yeah, let's stop and take questions.
Thank you. Covered a lot of ground.
Let me make one more point while we're waiting for the questions. All the last slides were basically to show that for single-sided deafness, BCSPs do not establish hearing in the deaf ear. Cochlear implants are currently the only way to do that. And there is growing evidence that the majority of patients with a cochlear implant can improve their ability to localize sound significantly better than they can with a cross or a BCSP device, and get some more binaural benefits in terms of hearing and noise. But it's highly variable and certainly not the case. Okay.
Yeah, we'll go to the questions. I was told by multiple AUDs, audiologists at Seattle Children's and Mary Bridge, that children with unilateral hearing loss need to wait until at least 5 years to get cochlear implants. Is there talk about changing this restriction if hearing technology can be helpful for children with unilateral hearing loss? I feel like daycare is quite a hectic auditory environment.
Yeah, that's a great question. So the long story short is our cochlear implant team and our OIB-CSP team, we will see patients for single-sided deafness really at any age. So for surgical options, we would consider, and we have implanted patients who are well below 5 years of age. We don't know if it's going to always be approved by insurance companies. We were pretty careful about doing that when the FDA criteria were first lowered down to age 5, because there was not a ton of data showing the effectiveness of cochlear implants, at least in very young children with SSD. But as the research has improved, we've liberalized that.
Well, questions are coming up. I'll say that the Oseo was recently updated to include a diametric magnet, which is more MRI compatible. And so that change, I think, has really made that particular device a better option. And Dr. Horn talked about kind of the two indications for these Oseo devices are ipsilateral conductive hearing loss or single-sided deafness, and the goal of the device changes in those different conditions. One is transcranial routing of sound versus stimulating the same-sided cochlea. So the next question, and that'll be our final question, do we have outcome data yet for speech recognition using the CI only?
Yeah, there's a number of studies that have reported that, and in general, the factors that determine speech recognition in bilateral patients are similar in terms of length of deprivation and etiology. What's interesting is I think people have assumed that speech recognition will predict things like how patients rate how much they like the device. And it turns out that there aren't very strong correlations, at least that are emerging quite yet. Jill first presented some data last year at ARO. I didn't go this year, but really nice data in a good data set showing that there's not a great link there. So you can get good speech recognition from a cochlear implant in SSD patients, but it doesn't always tell you how useful they're going to report that the device is.
Thank you. Thank you to everybody for attending and spending the past 4 hours with us. We've learned a lot. I've learned a lot, and certainly the information has generated more questions, which is, I think, the mark of a great presentation and discussion. So thank you to everyone for attending. Thank you very much to our presenters for sharing your expertise with us and doing it on time. So we hope that you enjoy the rest of your day, and Lisa will be sending out some information, some of the links that the presenters were referring to. And please let us know if there are other topics that you'd like us to present. We do a lot of planning for these. I'd like to particularly thank Dr. Tharp for joining us, and hopefully next time we can meet in person. To the presenters, Dr. Chang, Dr. Christensen, and Dr. Horn, and of course to Lisa Herbert, Janet Donnell, Linnea, and our interpreters. So thank you to everybody, and enjoy the rest of your day.